Hello, sir.
Yeah,
I'm not able to move the slides, sir.
You log off and log on again.
So it's live actually right now.
But he's
yes.
not able to move the slides. A
Uh,
slide,
Yes.
yeah,
yeah,
okay,
Yes.
fine.
yeah, okay,
You
right.
can go ahead, Sharon.
Good morning, sir. Good morning, Samvedam, sir. Good morning, Gansham, sir. Thank you for giving me this opportunity to present in Higgs platform. Today, my topic is about cytokine storm and hemophagocytic syndromes. My presentation objectives will be to understand the concept of cytokine storm, to find out the causes of cytokine storm, examine the pathophysiology both at cellular and molecular levels, identify systemic effects of cytokine storm, diagnostic challenges, review the management strategies, a note on hemophagocytic lymphohistiocytosis, preventive measures, and multidisciplinary approaches to mitigate the risks associated with it. Historical timeline. Sir William Osler has described in sepsis, except on few occasions, the patient appears to die from body's response to infection rather than from it. In 1991, the term cytokine release syndrome was first used by Alliger et al. In an experimental model of hyperinflammation. In 1993, first medical use of cytokine storm appeared in standard medical literature by Ferrari et al., who described the effect of interleukin 1 on graft versus host disease after transplantation. In 1996, Aikawa described the cytokine storm as the key pathway to multiple organ dysfunction syndrome following surgical infections and sepsis. So, cytokine storm is an umbrella term, just like this, encompassing several disorders of immune dysregulation characterized by constitutional symptoms, systemic inflammation, and multi-organ dysfunction that can lead to multi-organ failure if inadequately treated. CRS cytokine release syndrome is an acute systemic inflammatory syndrome characterized by multi-organ dysfunction. Why we should know about cytokine release syndrome? Cytokine release syndrome management is integral to development of newer immunotherapies, and understanding has provided fundamental insights into cytokine biology. Management strategies have further diversified applications in other inflammatory conditions. How cytokine storm can occur? It can be due to inappropriate recognition, ineffective recognition with immune evasion, inappropriate response with an exaggerated effector response on cytokine production, ineffective response due to immune evasion, or failure to terminate homeostasis or return to homeostasis. These are the various clinical causes of cytokine storm, where the causes include iatrogenic secondary to CAR T therapy, where CAR is chimeric antigen receptor T cell therapy. Blinatumab, where infusion of CD19 and CD3 specific T cell receptor antibodies, pathogen associated bacterial sepsis, EBV associated HLH, HH8 associated multicentric Castleman disease, COVID-19. We have seen many cases during COVID-19 as cytokine storms. Monogenic and autoimmune causes include primary HLH, secondary HLH, or macrophage activation syndrome, where macrophage activation syndrome occurs in adult onset still disease, rheumatoid arthritis. Autoinflammatory diseases are associated with germline mutations, sometimes idiopathic multicentric Castleman disease. No exact cause can be pointed out. Coming to COVID-19 associated cytokine storm, there is a correlation between nasopharyngeal viral load and cytokine levels in COVID, as well as a declining viral load in moderate but not severe cases, suggesting that there is an immune response that is positively associated with viral burden. Coexisting conditions like hypertension, diabetes, and obesity are associated with more severe cases of COVID-19, probably because of pre-existing chronic inflammatory state. Coming to causes, iatrogenic causes other than CAR T therapy, blinatumab include rituximab, gene therapies, immune checkpoint inhibitors, even cardiac bypass surgeries, allogeneic stem cell transplant, bioterrorism agents like staphylococcal enterotoxin B and Francisella tularensis. Coming to basic pathophysiology, and there is an exaggerated Th1 inflammatory response during cytokine storm. Th1 cells produce large quantities of interferon and gamma, inducing delayed hypersensitivity reactions, further activating macrophages. B cells are capable of initiating as well as propagating cytokine storm, particularly when cells are virally infected. At the pathophysiology, at the level of cellular, B cells normally produce antibodies, but in CAR T therapy, the lack of B cells lead to unchecked infections and cytokine storms. Autoantibodies may form worsening of inflammation. Macrophages M1 and M2, M1 is a pro-inflammatory, macrophage 2 is anti-inflammatory. Both can cause, they have a role in cytokine storm, where overactive M1 causes cytokine storm, whereas excessive M2, prolonged stimulation, poor pathogenic clearance. Neutrophils, there are considered to be first responders by phagocytosis, netosis, where net is neutrophilic extracellular traps and degranulation. High neutrophils have been associated in COVID, leading to poor oxygenation, leading to alveolar damage and higher ARDS risk. Coming to monocyte macrophage, there is a direct activation via Fc receptors, secondary activation by T cell derived cytokines. Endothelium direct activation by therapeutic agents, response to inflammatory mediators of cytokines, leading to further propagation, amplification, and endotheliopathy, capillary leaks, and others. Coming to molecular level, JAK-STAT pathway, neutrophil extracellular traps, NLRP inflammasomes, toll-like receptors. JAK-STAT pathway is a major signaling pathway activated by interleukin-6, interferon TNF. They mediate cytokine signaling, inflammation, immune response. Overactivation leading to interleukin-1, 6, GM-CSF, and systemic inflammation. Coming to neutrophilic extracellular traps, these are web-like DNA structures released by neutrophils to trap pathogens. They help in fighting infection by trapping and killing pathogens, but excess net have been incriminated in tissue damage, microthrombosis, ARDS, and have been found a role in COVID-19, severe COVID-19 infections also. Coming to NLRP3 inflammasome, it is a protein complex that gets activated in cellular stress signals and it releases interleukin 1 beta, interleukin 18. They are known to cause pyroptosis, where inflammatory destruction of cells can occur. It has a role in COVID-19, myocarditis, even viral pneumonia. Toll-like receptors, they recognize pathogens and trigger. We have found SARS-CoV virus spike proteins interaction with toll-like receptors. They are known to cause release of interleukin 1 beta, interleukin 6, interferon causing tissue injury, and not only in COVID and even other viral infections also. Coming to nuclear factor kappa beta activation, there are key cytokines including interleukin 18 TNF alpha leading to nuclear factor kappa B nuclear translocation causing gene expression. Amplification leads to further sustained inflammatory response. MAP kinase cellular stress response lead to MAP kinase activation leading to modulation of cytokine production and cellular response. This is a pictorial representation where there is a potential triggers like iatrogenic causes, pathogen causes, autoimmune causes. These are driver cells, driver T cells, innate antigen presenting cells, immune hyperactivation syndrome, cytokines, various cytokines, interleukin 1 beta, 18 interferon, these interleukin proteins. Those on light color are the therapeutic agents we aim to block at the cytokine levels. This at the nuclear levels, molecular level, MAP kinase activation, nuclear factor, JAK kinase. This lighter color is the target pathway in treatment. All these cytokines at cellular and molecular level cause to acute systemic inflammatory states, secondary organ dysfunction, multi-organ failure, and even death. Systemic effects and the cytokine correlation. CNS due to interleukin 6, TNF causing damage of blood-brain barrier. Symptoms include headache, confusion, seizures, aphasia, encephalopathy. There is an entity called ICANS. We will discuss it in further slides. Interleukin 1 is known to further worsen neuroinflammation, and anakinra and interleukin 1 blocker can be protective. Lungs, interleukin 6 is central, leading to immune cell activation. Pyroptosis of alveolar cells amplifies inflammation by Th17 differentiation. It can cause hypoxia, diffuse infiltration, alveolar damage, poor lung compliance may lead to ARDS. Liver and gut, liver hepatomegaly, elevated enzymes due to interleukin 1 induced damage of hepatocytes. Interleukin 6 stimulates acute phase reactants leading to hypercoagulability too. GI systems, nausea, vomiting, diarrhea, colitis may further lead to severe hepatic failure. Bone marrow stem cell suppression leading to pancytopenia, anemia, leukopenia, thrombocytopenia caused by interferon, gamma, TNF, interleukin cell, further leading to stem cell exhaustion at the bone marrow level. Microenvironmental changes seen in HLH and graft versus host disease, macrophages phagocytize hematopoietic cells here. Coming to heart, there is a reduced ejection fraction due to damage of interleukin 1, 6 TNF damage at the cellular level and impaired calcium handling. There is a shock because of secondary vasodilatory capillary leak and even cardiogenic related due to decreased ejection fraction. Sometimes arrhythmias, AF, VF, bradycardia can be precipitated. Kidney, there are immunocell infiltration due to and cytokine-induced vasoconstriction, microthrombi, complement activation leading to glomerulonephritis and tubular injury. Coming to risk factors associated with cytokine storm depends on the patient variables, treatment variables. Patient variables, disease burden of the malignancies, bulky load more than 5 cm in case of tumor, high circulating blasts, bone marrow involvement of more than 50%. Inflammatory state, already the patient has a high inflammatory state, acute infection, elevated interleukin 6, autoimmune diseases, prior therapy, history of recent CAR-T therapy or CAR-T failure, intensive lymphodepletion prior to any immunotherapy, recent checkpoint inhibitors, comorbidities like cardiovascular diseases, pulmonary diseases, neurological conditions. Treatment variables include, particularly to CAR-T therapy, CD28 co-stimulated domain, high cytokine products depending on the product, administration of the iatrogenic drugs like CAR-T, rapid infusion, no step-up dosing, inadequate pre-medication, lymphodepletion by cytosine fludarabine, timing within 48 hours of pre-infusion, and even high-intensity regimens. All these are contributors, risk factors for cytokine storm. Basic workup, coming to basic physical examination, diagnostic workup, general examination, vitals, CVS respiratory examination, abdominal examination, routine blood workup, complete blood picture, metabolic panel, coagulation studies, inflammatory markers, microbiology to rule out infections, imaging studies, chest X-ray, echo, and other images if necessary. Coming to symptoms, fever is the first and most important symptoms and is considered as a cardinal symptom. It does not exceed 40 degrees centigrade and temperature pattern may vary from continuous versus intermittent. The onset and duration may vary according to the agent given. In CAR T therapy, fever usually occurs within 5 to 7 days. Sometimes they may occur even after 20 days after infusion. But within hours after administration of monoclonal antibodies, fever occurs. Fever can be mistaken for infection, but it is not possible to distinguish the two factors. So empirical treatment, antibiotic treatment should be treated after collecting appropriate cultures, particularly in neutropenic patients. This is the vital chart after CAR T therapy. Initially, the blue one is the tachycardia, pulse rate. Red one is the systolic BP. This is the temperature rise. See, within 5 to 10 days, there is a fever spike. Even sometimes after 20 days of CAR T infusion, there is a chance of fever spike. There is a fall in BP, there is an increase in heart rate. Coming to other constitutional symptoms, fatigue often precedes fever and may persist beyond resolution of other symptoms. Myalgia and arthralgia due to cytokine effects of muscles on muscles and joint tissues. Headache considered to be an early neurotoxicity indicator. Others, gut nausea and vomiting to an extent of limiting oral intake, necessitating IV hydration. Diarrhea less common but significantly present, needs to differentiate from other causes. Hepatic transaminase is common in moderate to severe cases. Hyperbilirubinemia has also been reported. Skin generalized maculopapular rash, erythema. Severe presentation may lead to hypotension. Hypotension is considered to be a defining feature of a grade 2. The grading will come in the next few slides. The response to fluids distinguishes grade 2 from grade 3, where IV fluid itself decreases hypotension response to IV fluids in grade 2, but may require vasopressors in grade 3. In capillary leak is considered to be a refractory hypertension. Cardiac dysfunction, elevated troponin, reduced ejection fraction, arrhythmias, pulmonary hypoxemia, non-cardiogenic pulmonary edema, diffuse alveolar damage, rapidly evolving ARDS. Coming to neurological, neurotoxicity syndrome, immune cell associated effector syndrome may persist even after cytokine release syndrome resolution. Encephalopathy state like altered sensorium, seizures, aphasia, cerebral edema. Renal may be due to renal effects like acute kidney injury may need renal replacement therapy. Hematological issues, coagulopathy, increased D-dimer, fibrinogen, APTT, PTINA, cytopenia, thrombocytopenia common, in severe cases lymphopenia, neutropenia. Summary, in case of CAR T therapy, there is an entity called ICANS, immune cell associated neurotoxicity syndrome, will come in the next slides. These are all pictorial representation of the various effects of cytokine release syndrome: lungs, pneumonitis, edema, dyspnea, hypoxia, ARDS, liver hepatomegaly, enzymes, hypoalbuminemia, hyperbilirubinemia has also been reported, though rare, liver injury, cholestasis, liver failure, kidney, acute kidney injury, vascular system cytopenias, coagulopathies, vasodilatory shock due to capillary leak syndrome, spontaneous hemorrhages, constitutional symptoms, neurological confusion, aphasia, seizures, fever, fatigue, heart hypertension, tachycardia, and others. This is AST, American Society of Transplantation Cellular Therapy consensus grading of cytokine release syndrome. Fever more than 38 degrees present in all grades. Hypotension not requiring vasopressors but responding to IV fluid bolus. Hypoxia requiring less than 40% of oxygen. Grade 3 is requiring vasopressors to maintain the BP. Requiring high flow oxygen considered as high HFNC, NRBM or Venturi mask. In grade 4 requires multiple vasopressors excluding vasopressin, requiring positive pressure ventilation, mechanical ventilation. These are other classifications, but we usually follow AST CT grading scale. Coming to biomarkers, no single cytokine tells the whole story. Multiple markers should be tracked over time rather than relying on one measurement. But the challenges include no standardized thresholds for cytokine measurements. Measurement methods may vary according to laboratory. Baseline cytokines may already be elevated in cancer patients. So always consider the ratio to the baseline or relative increase rather than absolute values. CRP correlates with severity and treatment response, but later than the other cytokines. Ferritin more than 20,000, CRP more than 150 mg per liter may help distinguish CRS from infection. Neither CRP nor ferritin alone are sufficient as predictive markers. Coming to various biomarkers workup, interleukin 6, 10 interferon TNF alpha. Acute phase reactant CRP lags behind cytokines, but cost-effective monitoring more than 150 is considered as grade more than or equal to 3. Procalcitonin to an extent helps in rule set infection, but we cannot solely depend on procalcitonin. Coming to interleukin 6, in severe cases more than 100, even thousands, and it is considered to be a target. Differential diagnosis includes infection, tumor lysis syndrome, HLH, Marsh syndrome, macrophage activation syndrome, engraftment syndrome, DRESS, anaphylaxis, and others. Coming to cytokine storm in specific context, CAR T therapy and cytokine release syndrome. Cytokine release syndrome incidence depends on the type of the product of CAR T therapy. These are all various incidences of the cytokine storm in relation to the type of the product of the CAR T therapy. Strong association between disease burden and CRS severity, particularly evident in B-cell malignancies. So this needs a tumor debulking strategies prior to CAR T infusion. P coincides with the expansion of the CAR T therapy. Other therapeutic contexts, monoclonal antibodies have variable risk of cytokine storm. Haploidentical stem cell transplant, there is a moderate to high risk of cytokine release syndrome. NK therapy, there is an emerging evidence that they too all cause CRS syndrome. Coming to bispecific antibody, BiTE cells, bispecific T cell engagers, dual affinity retargeting proteins, similar mechanism to CAR T. These are all various agents, blinatumomab, teclistamab, but they have cytokine storm associated with bispecific antibodies appear earlier than the CAR T therapy, usually within 24 hours, but have shorter duration. Checkpoint inhibitors delayed even weeks to months. Any grade can occur, severe cases less than 1%. Prevention of cytokine storm in a particular setting, tumor debulking before CAR T therapy to decrease the release of cytokine release syndrome and neurotoxicity. Splitting dose or step up, gradually increasing the dose is needed. Prophylactic tocilizumab to prevent the reduced severity of cytokine release syndrome, modified condition regimen, host factor modification, even CAR T product, if genetically altered to an extent, can decrease the cytokine release syndrome. This is the grading management, grade-wise management, grade-wise supportive therapy in grade 1, fever control, close monitoring for progression in high-risk patients, consider tocilizumab. Grade 2 tocilizumab first-line treatment, IV fluids usually respond, hypertension IV response usually to IV fluids, low flow oxygen needed, consider steroid, repeat tocilizumab if needed. Grade 3 immediate tocilizumab, add steroids, vasopressor support, IC level monitoring, second dose of tocilizumab. Grade 4 tocilizumab, high dose steroid, methylprednisolone in case of neurological involvement. Multidisciplinary treatment, intense organ support is needed in grade 4 CRS. Coming to pharmacological interventions, tocilizumab acts against interleukin 6 receptor level, prevents interleukin 6 signal transduction. Dosing regimen 8 mg per kg, maximum 800 mg per dose, repeat dose in 8 to 24 hours in adequate response. Maximum 3 doses in a 24-hour period, no dose adjustment in a renal failure. Efficacy, resolution of fever within 4 hours, improvement of hypertension 60 to 65% within 24 hours, reduction in vasopressor response, decrease progression to higher grade CRS. Siltuximab is another drug where tocilizumab acts at the interleukin 6 receptor level. Siltuximab acts at the level of interleukin 6 direct cytokine. Half-life is more, but limited case series. Coming to steroids, they act at genomic levels, transcriptional regulation, non-genomic effects include membrane stabilization, cellular targets, T cells, monocytes, neutrophils. Early versus delayed administration, earlier use with tocilizumab in severe cases. Dosing regimens, methylprednisolone 1 to 2 mg per kg, severe neurotoxicity may go up to 1 gram per day. Alternative, dexamethasone for better CNS penetration. Tapering strategies, rapid taper, extended taper, keep on monitoring for fever, CRP, hemodynamics. Anakinra is an interleukin 1 antagonist used in tocilizumab refractory CRS and neurotoxicity. JAK inhibitors like ruxolitinib in steroid refractory cases and tocilizumab resistant CRS. Anti-TNF strategies, infliximab, etanercept, where TNF predominant CRS is found. Combination therapy in refractory cases is useful. This is again a repetition of grade-wise management. Grade 2, 3, 4 tocilizumab started. Consider tocilizumab even in grade 1, even prophylactically in some cases. Dexamethasone in case of CN for better CNS penetration. Steroids. Switch to methylprednisolone 1 gram per day in case of grade 4. Other intensive care management, organ support continues. This is an immune cell effector associated neurotoxicity syndrome, ICANS, graded according to I score, where I is immune cell associated encephalopathy. Depending on the I score and manifestation is divided into grade 1, 2, 3, 4. Management includes seizure control, neurological specialist consultation, supportive care, fundoscopic EEG measurements, tocilizumab in grade 1 itself, dexamethasone with high dose from grade 2, seizure control, fundoscopy, CT MRI, even lumbar puncture if needed, anti-edema measures if needed. Extracorporeal support, a patient with severe cytokine release syndrome unresponsive to tocilizumab, steroids, and supportive care can be treated with cytosol. The rationale here is interleukin 6 rebound. Tocilizumab blocks at the interleukin 6 receptors, but this may lead to increase in plasma interleukin 6 levels. These interleukin 6 levels can cross blood-brain barrier, leading to worsening of encephalopathy. There is a multi-cytokine storm with involvement of other mediators also, which cytosol can efficiently remove. Compartmentalized inflammation, cytosol addresses cytokines in circulation unlike receptor blocking drugs. The intervention by reducing key cytokines can be useful as an adjunctive therapy. These are all various studies we have tried cytosol in COVID patients and others where treatment with cytosol, Voxarus we have tried. Coming to HLH, what is HLH? HLH is hemophagolymphohistiocytosis. Heme blood phagocytosis of a cell that eats lymphocytes, expansion of lymphocytes, histiocytosis, expansion of eating type cells, macrophages. Key concept, lymphocytes and histiocytes are immune cells and they expand into an angry mob causing damage to the patient body. Uncontrolled inflammation, this is HLH, macrophage activation syndrome, cytokine release syndrome. This is all called as an immune wildfire where there is a loss of control leading to uncontrolled inflammation. Pathophysiology, immune dysregulation, cytokine storm, role of interferon, TNF alpha, defective cytotoxic function, perforin grangium pathway, genetic mutations, all these triggered by infections, malignancies, autoimmune diseases. See, this is a central pathway, uncontrolled persistent activation of lymphocytes caused due to cytotoxic defect, inflammasome dysregulation, macrophage activation, leading to interleukin 8 stimulation, excessive antigen in case of infection. All these lead to uncontrolled persistent activation of lymphocytes, interferon gamma release, activation of macrophages. These are all triggers: infection, malignancy, autoimmune, CD8 cells, activated CD8 cells releasing interferon gamma, interleukin, cell infiltration. Sometimes cytolysis is inhibited, leading to uncontrolled activation of CD8 cells. Etiology is primary and secondary. Primary includes familial and genetic, secondary infection associated, malignancy associated, macrophage activation syndrome in autoimmune diseases, SLE, Still's disease. Familial, early onset, usually appears in early childhood, monogenic caused by genetic mutations, fixed defect treatment, ultimate treatment is stem cell transplant. Whereas secondary occurs in older children and adults, no clear genetic cause has been identified, triggered by infection, malignancy, autoimmune case. There is chance of recurrence, even though minimal. These are all secondary causes. Infections with large antigenic load, virus, EBV, HIV, CMV. In Indian scenario, even dengue, malaria, malignancies like hematological malignancies, leukemia, lymphoma, macrophage activation syndrome, autoinflammatory diseases, autoimmune diseases, cytogenetic CAR T therapy. Other causes like organ transplant, stem cell transplant, metabolic disorders, trauma, immunosuppression, vaccination, surgery, hemodialysis, even in pregnancy, though rare. This HLH syndrome overlaps where familial is by definition genetic. Rheumatological macrophage activation, perhaps genetic modifiers and risk factors exist. Malignancy by definition related to cancer, which is an acquired. Iatrogenic secondary to treatment, HLH with immunocompromise due to specific genetic disorders like chronic granulomatous diseases. Other is HLH not otherwise specified. Coming to diagnosis, there are two criteria, HLH diagnostic criteria versus HLH score. HLH criteria is now total criteria 8 developed for pediatric population for primary HLH, includes NK cell function but does not include liver function. Sensitivity is 91%, specificity is 93%. Whereas H score includes 9 criteria, particularly developed for adults with secondary HLH, does not include NK cell but includes liver function. 169 cutoff H score, sensitivity has 96 and 71% specificity. This is the diagnostic criteria, molecular diagnostic consistency with HLH or a fulfillment of 5 of the following criteria like fever for more than 7 days of more than 30 degrees, splenomegaly, cytopenia of hemoglobin less than 9 platelet, neutropenia, increased ferritin, increased TAG levels, decrease of fibrinogens, hemophagocytes found on bone marrow, spleen or lymph nodes, absent or low NK cell activity, soluble SD interleukins more than 400 units per ml. This is a H score. depending on the score 0, 18. If there is an immunosuppressed HIV positive long-term immunosuppressive therapy, steroid, cyclosporin, azathioprine, presence of fever, organomegaly, cytopenia, ferritin, TAG, fibrinogen, AST. Here liver function has been included, AST, hemophagocytes on the bone marrow. Coming to basic approach, 5-step clinical pathway. Identify the hyperinflammation, identify by clinical and lab sense of cytokine storm, identify the treat the trigger, investigate for infections, malignancies, or autoimmune diseases. Try to calm the hyperinflammation by initiating immunosuppressive therapy, steroids, IVIGs. Determine the underlying immunological defect, particularly in primary HLH, by genetic testing. Replace the immune system by stem cell transplant for genetic forms. To identify and treat the trigger, hemophagous HLH does not occur spontaneously. Always look for a new trigger for every flare. Look for initiating stimuli like infection, malignancy, or self-antigen. Coming to workup, key patient history, family history, recent infection, recent travel, even dengue, malaria are known to cause in HLH in an Indian scenario. Malignancy and rheumatological disorders, clinical findings always correlate with the HLH criteria and H score. Imaging if needed. All lab evaluation, ferritin, TAG, fibrinogen levels, specialized testing, if available, histopathology for confirmation in some cases. Try to reassess every possible way. Unexplained fever with sepsis-like syndrome. Check for falling in counts, poor counts, failing blood counts, extramedullary diseases. Suggestive HLH, fever, cytopenia, splenomegaly, calculate H score. If H score is more than 169, and along with high suspicion, multidisciplinary team discussion and daily HLH scan with comprehensive investigation. Whereas if H score is less than 169, even then, if there is high index of suspicion, repeat test daily, raising score. First line treatment is a steroid and or etoposide. Second line treatment an anakinra, interleukin 1 blocker. Third line treatment is stem cell treatment in case of refractory cases. This is an induction phase HLH 94 protocol. Induction phase, consolidation phase, DEXA 10 mg per meter square, initial 5 mg per meter square. This axis is in weeks. VP16 is etoposide 150 mg per meter square. CAC is cyclosporin with a target of 200 microgram level trough levels. Intrathecal therapy can also be tried with methotrexate as per age and dose. Start only if there is an abnormal CSF not proven or if there is progressive neurological symptoms. Salvage therapy, early mortality is a major concern in HLH. If even 50% of primary HLH patients fail initial etoposide therapy, no standard treatment exists for refractory or relapsing HLH. Salvage therapy, alemtuzumab CD52 directed cytolytic monoclonal antibody, anti-ATG, anti-thymocytic globulin for T cell depleting antibodies, ruxolitinib for Janus kinase inhibitor, anakinra, interleukin 1 antagonist, liposomal doxorubicin, imaprimumab, anti-IF and gamma monoclonal antibody. This is the management of a secondary HLH. If the patient is clinically stable, identify, always treat the trigger. Always general considerations continue, optimize supportive treatment, check for secondary infections, reassess for potential trigger, reassess, if needed, terminate immunosuppression. Primary, find out the genetic history, genetic finding cause is most important in primary HLH. HLH 94 treatment protocol as discussed. Final ultimate treatment is allogenic stem cell transplant. For secondary cases, infection, EBV and other viruses, corticosteroids with or without IVIG and virostatics with modified HLH 94 protocol. Leishmaniasis, liposomal amphotericin B, always treat case by case. Malignancy associated triggered corticosteroids with etoposide pre-phase chemotherapy. Autoimmune inflammatory disease, high dose methylprednisolone, interleukin 1 blocker. Drug induced like CAR-T, we have already discussed interleukin 6 blocker with tocilizumab has a role along with corticosteroids. Always if there is an insufficient response at any phase, try to introduce etoposide. Other salvage options have already been discussed like alemtuzumab, ruxolitinib, even plasma exchange, cytokine absorption. What exactly is known? Standard therapy considered to be works properly, but how often do the patients respond to standard therapy? How completely do they respond? Is there any treatment modifications or adjustment done while treatment of the patients? How often were alternate treatments used is a gray area. Patient outcomes treatment is difficult, but what are the patterns of hospitalization in HLH patients? How often is ICU care required? How often does HLH treatment itself cause serious failure or serious injury or organ failure? We are missing a global data. All our expert opinion, potential expert bias is there. Clinical trials are limited, small sample sizes, registries or geographical limitations like German registry and others. Key takeaways: cytokine storm, life-threatening inflammation, hyperinflammation caused by infections, immunotherapy or autoimmune conditions. Key cytokines: interleukin 6, TNF, interferon, gamma, interleukin, drivers of systemic inflammation and organ damage. Organ damage: CNS, lungs, heart, liver, kidney, bone marrow, and almost every part of the body. Diagnostic challenges: fever is the hallmark. Biomarkers are important. Always need to differentiate CRS from sepsis, which is not possible always. CAR-T therapy risk: CRS and immune cell associated neurotoxicity syndrome occur 5 to 7 days, usually occur 5 to 7 days after infusion. Coming to HLH, uncontrolled macrophage lymphocyte activation, multi-system failure, genetic or secondary. Secondary, always consider a trigger. Treatment strategies have already been discussed: tocilizumab, steroids, refractory cases, anakinra, even cytosorb has been. Cytosorb that removes excessive cytokines has a role. Managing cytokine storm in a critical care, HLH and cytokine is a ultimate cytokine storm. Maintain high index of suspicion for cytokine storm in patients with persistent fever, cytopenia, multi-organ dysfunction. Time is tissue. Early immunomodulation improves survival. Engaging critical care specialists immediately when HLH is suspected. Multidisciplinary approach with hematology, rheumatology, and ICU teams is essential. Thank you.
Thank you, Krishna. I think it was an excellent recap of a contemporary topic. What came into our notice during the COVID pandemic, although it must have been existing before, we understood what it is, or probably tried to understand what it is, which triggered the whole cascade of this concept of thromboinflammation in sepsis. Now will be seen more often in the ICUs because of increased use of increased admissions of onco patients in the ICU and their arrival of CAR-T cell therapy in a big way in Indian oncology scenario. I think this was a much needed topic, very comprehensively covered. It's a big topic, but I guess you were able to condense it and put the essential information in a nutshell. The important aspect is when sepsis flares and you have a systemic inflammatory response, the borderline between a systemic inflammatory response and a cytokine release syndrome is very, very narrow, and differentiating both is very difficult, especially when there is viral infections. It can mimic sepsis, it can mimic a cytokine release syndrome. How to intervene, we've already heard. What is the role of extracorporeal filters? We don't have concrete evidence, but it does make sense in trying to remove some of these cytokines, although the filters we have currently are broad spectrum filters. I think there's a lot more to happen on this, and more advances are expected to happen in the field of cytokine release syndrome. Ghanshyam, you want to add anything?
Nothing much from my side, Srinivas. The only thing is, I think for a long time, whatever abnormalities we used to see in the cell lines, in especially patients with sepsis, we did not have much options. We always used to think that the sepsis-induced bone marrow suppression or sepsis-induced thrombocytopenia. But I think these entities are something that we need to keep in mind because these do have a definite therapeutic strategy. So just keep in mind in situations where you are not able to explain the abnormal cell lines, the abnormal inflammatory response with the conventional infection or sepsis, you could be dealing with one of these entities.
Yeah. Okay. Thank you. So thank you, Krishna, for the presentation. If you have any queries or comments on this topic, please do post them on the group from where you got this link from, and the speaker and one of us will answer the queries at the earliest possible opportunity. Please do register for the upcoming HICS conference on 19th to 22nd of June, the 10th edition of HICS. Few slots still available for registration, and subscribe to the YouTube channel. Thanks for joining us this morning, and hope to see you again next Tuesday at 8:15. Thank you.
Thank you.